All right, let's get started. Good morning. This is Dr. Howard Haft. I'm the Executive Director of the Maryland Primary Care Program, and it is my extraordinarily great pleasure to be joining you with this webinar this morning about our Avoidable Hospital Events tool. This was something that we've been looking forward to for the better part of a year, and happy to be having that launched very soon. We will be doing an ensemble presentation this morning. I will begin the presentation talking about what prevention quality indicators really are, giving you a little bit of background on that. And then we will move to Dr. Ian Stockwell, who is from the Hilltop Institute at the University of Maryland, Baltimore County, who will talk about the background on Avoidable Hospital Events tool and some details of the tool. And then we will move to a live demonstration by Audrey Spader from CRISP and H-Metrics, and finish up with some next steps and questions and answers. So let's begin. So many of you will be caught short in saying, what is a prevention quality indicator, or PQI? And this is really something that's been around for a long time in the healthcare world. It's been predominantly focused on hospitals, and it's a measure, a quality measure of sorts that's used to identify admissions to hospitals that may have been avoided through the intervention of high quality outpatient care. Hospitals often use these to track admissions that are related to what they call, or what hospitals call, ambulatory sensitive conditions, or ASCs. Those conditions that, again, can generically be cared for in the outpatient or primary care office level. And it's also used as a guide for overall admission rates that could be improved by doing more with advanced primary care, which is what our program is, and at the heart of what we're doing. A couple of examples of this might be, for instance, an individual who's admitted for chronic obstructive pulmonary disease, COPD, who may have avoided that admission if they had been seen in an ambulatory setting or by a primary care provider and gotten an immunization or a refill of their inhaler, or had an earlier intervention with an antibiotic for something that turned into a more significant condition. Such is true also for things like diabetes, short-term complications, those things when people's diabetes get out of control, which is obviously something that can be managed proactively in the ambulatory setting for the most part. Congestive heart failure, which can be managed with aggressive weight management, medications, and other things that are best done in the ambulatory setting. And conditions like pneumonia, where clearly someone who develops a pneumococcal pneumonia could have largely been prevented by giving an immunization. So those are sort of the categories. There's other things in that category, but these are fairly emblematic of what the kinds of conditions that we're talking about when we're talking about providing high-value care in the primary care setting, and things that can be intervened to avoid these PQIs. So what's the Maryland primary care role and the broader role within the total cost of care model contract for reducing PQIs? As you probably know, the total cost of care contract, which was entered into by the state in July of 18 and began in 19, committed the state to reducing Part A and Part B Medicare spending by 2023 to an annual run rate of $300 million less than what it was at the baseline. Our presumption is when that goal is reached, in addition to other associated quality goals and things that we've committed to doing with our federal partners, that this model that we're in now will become the permanent way we deliver health care and pay for health care in the state of Maryland. Well, it comes to our attention, and has been known for a long time, that if we're going to reduce hospital spending, that one of the prime targets would be reducing that hospital spend that is better cared for in the ambulatory setting. And we know that PQIs, these ambulatory sensitive conditions, account for over $400 million in these Medicare hospital spend on an annual basis in Maryland alone. We also know that the investments that are overall made in the program, in the Maryland Primary Care Program, are not investments that are ignored by the federal government. They are in fact included in this overall spending calculation that we have for the state. so that the investments that come to primary care are in many ways looked at as, well, they're investments that are made in primary care, but we can use those investments at a minimum to reduce these avoidable utilizations, and so thereby offset the investment. We know that the investments are used for many, many, many other things besides just avoidable utilization, but that's a financial test for how effective those investments are. So an MDPCP does rely on being able to offset the investments that are made in the program by the good work that's done, including avoiding unnecessary utilization. So let's just take a look at what the real costs are for PQIs. And this is Maryland data. It's the source is our Health Services Cost Review Commission. And you can see over the years, there's been a fairly steady amount of very significant amount of hospital spend that's attributed to what we call PQIs. And even as 2018, you can see that the overall all-payer spend was in excess of $800 million, which is obviously very significant, and more than $400 million in 2018 just for Medicare fee-for-service patients only. Doesn't include Medicare Advantage and other, but just those Medicare fee-for-service beneficiaries. So this is obviously a big target for us. So in order to address this issue, we began to work with the Hilltop Institute at UMBC, together with the Department of Health and our colleagues at CRISP, in a collaboration that began actually more than a year ago. And the collaboration was about looking at data and literature and science and seeing if there were tools or a specific tool that we could provide to all of our MDPCP participants that would be very specific to guiding to how to reduce this unnecessary utilization. It was funded both by the state and by high-tech grant monies. And what turned out to be a really first of its kind program that will be available over the entire MDPCP span, which covers the entire state, focused specifically on reducing unnecessary utilization, and uniquely, not just for inpatient utilization, but as you'll hear in several slides forward, it also addresses emergency department utilization. And the phase 1 of this program is to be released very soon, within the next few days. There'll be ongoing enhancements to this program, but felt this is so important, and the data that we saw early on was so strong that we didn't want to wait to release this any longer. So the purpose of the program is to support providers and your care management staff to identify and intervene and engage with attributed fee-for-service beneficiaries that need care and coordination, who have been identified specifically being at risk for avoidable utilization. And this is avoidable utilization in the very near future, in a 30-day window looking forward. And this is so ideally suited to what we've been talking about throughout the course of the MDPCP program in terms of using two-tiered risk stratification, because the first tier in this setting would be the risk stratified patients who could be identified by the tool, and the second tool would be using that great clinical intuition of our providers to be able to look at that list of patients and say, yes, yes, no, yes, this is what we need to do for these patients, and provide further guidance on that list. It's just ideally suited to that. And this has been developed to allow practices to meet those needs and really to address the needs not only of the program, not only of the hospitals, but specifically of our patients, to allow those patients who can be intervened at the practice level to have those appropriate interventions in a timely fashion. So I am going to stop here and turn the presentation over to my colleague, Dr. Ian Stockwell at the UMBC Hilltop Institute. Ian?
Hi, thanks, Dr. Haft, and good morning, everyone. I'll start with a broader overview of the tool and some of the mechanisms of how it works. So early on in our collaboration with the Maryland Primary Care Program, it was very apparent that the types of risk identification tools that were available out in the field were focused specifically on identifying financial risk. So the characteristics of beneficiaries and the effect of those characteristics on a subsequent period's spending. And it became clear after talking with the folks at the Maryland Primary Care Program that what really was needed was an event risk model, and that's what we sought out to build. So after an extensive literature review and significant data modeling, what we came up with was the Avoidable Hospital Events tool that we nicknamed Pre-AH. And this is built on our time to event statistical modeling framework. So it's something that we've used in other applications before, and it's, again, specific to not predicting a patient's financial risk, but instead an event risk. And as Dr. Haft said earlier, that event that we're predicting in this case are inpatient admissions that meet one of the PQI conditions, or non-admitted emergency department visits that meet one of those PQI conditions. More information on what those conditions are and how we do that assignment can be found in the full data manual. I won't really get into it here. But the idea was to build a statistical model, a machine learning model that will distill all of the clinical and environmental information that we have for each beneficiary into this one metric, this likelihood of an avoidable hospital event that could then be sent to providers and care transformation organizations and care coordinators through the CRISP practice dashboard. And our colleague Audrey will show you what that looks like a little bit later. So next I'll kind of go through the process of the development of the tool. So, you know, one thing that we do here at UMBC is not kind of the big data mining approach where you take all your data and you throw it into big computers and see what pops out. We really wanted to base it in clinical theory, right? So we started with a very extensive literature review, over 3,300 papers, and the goal of that review was to identify what the academic and clinical researchers have found to be those significant predictors of an avoidable hospital visit or an ED visit. So that literature review kind of lent us this basket of potential factors, of which we have over 200 in the model right now. And with those factors, we could build statistical models that would assign those clinical factors to each beneficiary at a given point in time. We also have the algorithm to identify the PQI qualified inpatient admissions and ED visits. So in conjunction, the clinical milieu and the PQI events, that was the data that we built and trained our algorithm on. It does quite well in our sensitivity, and we know and are certain that it's going to do as well in the field. And again, this is not built as kind of an academic research, you know, tool. It is built to be used. And so our implementation plan, after we have done our extensive testing and sensitivity analysis here, is to retrain the model every quarter and to score each beneficiary every month. So every month when we get our new feed of Medicare data, we'll generate new likelihood scores for each beneficiary, and those would then go out through CRISP. Next slide, please. So those scores are really meant for a broad array of users. We hope that providers and care managers and anyone who is assisting in that care management, CTOs, can use that tool. And we hope that's true because it does distill a huge amount of information based on environmental risk factors and clinical history into one simple metric, and that is the likelihood that in the next month a given beneficiary will have an avoidable hospital event. And we hope that that is a very useful distillation and can really be actionable at the provider and practice level. Next slide, please. So we hope that the workflow is going to be fairly straightforward in using the tool. We will produce new risk scores every month that will go into CRISP. We hope that these risk scores are not, they are certainly not used to replace clinical judgment on which patients in a given panel need care coordination the most, but it's meant to augment that judgment and really be used, as Dr. Half said, in conjunction with the clinical expertise at the provider and the CTO level. So there are multiple ways of accessing these data. You can just pull it up within your CRISP dashboard and view it there. CRISP also offers the opportunity to download an Excel file if you want to pull it in and do your own data manipulation. But by default, this list is sorted in descending order by the risk of that avoidable hospital event, right? So when you pull up your panel, you'll have the most riskiest person, the person with the highest likelihood of that avoidable hospital event at the top, and the person with the lowest likelihood at the bottom. And what we hope is that that ordering can really drive the allocation of care coordination resources, where you start with the riskiest person and work your way down. Next slide, please. So, for those of you who aren't familiar with the CRISP reporting suite, we have a link here. It will show up as, and Audrey will show in a little bit, it's baked into the existing MDPCP reports. CRISP does have some technical requirements for accessing the site, and those are listed below. And with that, I will hand it over.
Good morning, everyone. This is Audrey Speeder with H-Metrics as a partner to CRISP. I will spend the next few minutes walking you through the actual report, and then we'll turn it back over to Chad to wrap things up. So before I jump into the report, just to summarize what we've heard so far about the goal of this report, and we've identified that goal as being able to easily identify those beneficiaries with the highest risk of experiencing an avoidable hospital event in the next 30 days. So you're going to see a fairly straightforward dashboard at this point. It's going to be a static list of your beneficiaries with their risk clearly identified for you. We provide a lot of beneficiary level information to help you further filter down your results or make these risk values more actionable. And we cover a series of beneficiary demographic information, name, NBI, gender, date of birth, and age, as well as Medicare status, dual eligibility, and program level factors such as your practice ID and HCC tier. As Ian mentioned, these reports can be exported into Excel for external analysis and purpose. We recognize that a lot of practices will need to take this information on the go. So be able to export the information, filter further, and then share with care partners as needed in order to make the risk score truly actionable. And last, we have a help section that I'll walk you through that has technical specifications and user manuals for all of these reports. So with that, I'm going to, if we can stop sharing, I can jump over. Okay. Okay, on your screen now, you should see your population summary for the MDPCP reports. I hope all of you are very familiar with this reporting suite at this time, so I'll be focusing only on our new report. So when you first log in, you'll see your population summary page, and there are now two ways to access this new report. The first is going to be through this bubble, the rank of avoidable hospital events. This will be a change from what you have currently seen in your reports. So with our release tomorrow, this bubble will now be the rank of avoidable hospital events and contain a quick link to jump you over into the actual report. The other way is to see the likelihood of avoidable hospital event link on your left side menu. They'll both get you to the same place. So by hovering over your bubble, we can access our report directly. And this will get us right there. So before I go through the report, just to get us grounded, we are looking at demo data. All information you see here is fictitious, does not contain any PHI. For the purpose of our demonstration, we are within an individual CTO, and we are within an individual practice. So for this practice, we have our beneficiary level information, and I'll go across those columns with you now on the right side. So to start, we'll have our MBI and beneficiary name, gender, date of birth, and age. All of these, of course, will certainly be helpful in order to get additional information on these beneficiaries within your practice. We've also provided the Medicare status and the dual eligibility status for each of the individuals, as well as the practice ID and HCC tier. Just a note on this HCC tier, currently in your MDPCP reporting suite, you will see the tier identified as a risk tier. Just to not confuse the idea of the risk that we're talking about in our new likelihood of avoidable hospital event data report with HCC risk, we have renamed all HCC-based measures as such. So you'll see HCC tier and you'll see HCC risk, starting with the update tomorrow morning. It's the same information, just a change in label. Next is the real meat of the report. This is your likelihood of avoidable hospital event indicator, a risk score, I could say. And as Ian introduced us to, this is the likelihood of the beneficiary experiencing the hospital event within the next 30 days. And we present that to you as a percent risk. And our last column is our claim payment amount. This is the total cost of care for the beneficiary within the last 36 months. So to help you clearly identify those beneficiaries with the highest risk, we first present this information in descending order, but we've also added some conditional formatting to help you right away identify the risk of the beneficiary within tiers. So we have introduced this risk score key at the top, where all beneficiaries within your top first percentile are going to be in red, those within the second to fifth percentile in orange, and likewise all the way down to the top 20th percentile. Following that, everything will appear in gray. So we hope this provides you with the information that you can quickly look at this list. You can look at the actual score, but you can also look at the color formatting to identify the level of risk relative to others within your practice. So one other thing I want to introduce you to is the conditional formatting is based on an individual practice. If you are operating from a CTO and have the ability to have more than one practice shown, I'm going to pull that in right now. I want to show you how that conditional formatting works across practices. Since it is, whoops, and that jumped us right back there. Let's get back in. Since the color formatting is operating within a practice, when you pull more than one practice in, you may see some jumps in your colors. Effectively, what this means is the threshold to represent the percentile bands for one practice may not represent that same band for another practice, as it's based on the distribution within a practice. So you'll see here that for practice ending 365, the first percentile ends at about 7%, whereas the percentile for the practice ending 370 is closer to 5%. So we just want you to be mindful of those differences as you review this report, but we hope this allows you to easily identify the high-risk beneficiaries within each practice, even while you review it across practices. Okay, one other point on this report is that we allow you to search by ID number or member name. So if you have identified beneficiaries elsewhere from other MDPCP reports or details, you're able to do a search within here, pull up the beneficiary row, and see their risk. So now, once you have kind of a good handling on how the report works, we want to introduce you to the Excel function. So you're able to now download your report into Excel. By clicking on Excel, you're going to see a notification that you're about to download PHI. Just please be mindful of that as you share this report with others in your organization. I have already done so here. So the Excel export of the report looks exactly like the table within the report. But now we have the ability to sort as needed. So with your Excel filter functions, we encourage you to filter your subpopulations, sort your population, so that you're able to best identify the subpopulation that you are looking to target. And we hope these features make it more easy for you to make the report actionable. And again, you can filter it by practice ID if you are downloading more than one practice at a time. Okay, I think that covers this report. The last thing I want to draw your attention to is the help menu here. And when selecting your help menu, you're going to be brought to the overall MDPCP report help screen. We have some new references here that I think will be helpful in your use of this report. So within the user guide, we have a section dedicated to this report. You'll see now likelihood of avoidable hospital events starting on page 27. It introduces the report, contains some screenshots, and helps you just understand each of the terms that are used and how they relate to each other. We have also added the pre-AH risk score specification document. This is Hilltop's full 80 pages in all of its glory, technical specifications for their risk score. So if you want to understand how the risk score was developed, the components that went into it, this will be the best reference for you to understand. And last, there is a quick reference for the model. This is if you missed this training or want a quick recap of this training and don't want to go through the full specifications from Hilltop, this is a short PowerPoint presentation with screenshots to help you understand how to access the report and how you can use it. And last, while I'm on this screen, there is a new disclaimer here that if you have any questions about this report or any of the other MDPCP reports, we welcome you to submit your questions to mdh.pcmodel@maryland.gov, and those questions will get triaged to the appropriate individual, whether it be technical questions addressed Hilltop will handle, or report functionality will come back to H-Metrics and CRISP. So with that, I think, Chad, I'll turn it back over to you.
Thank you, Audrey. Appreciate it. If you can pull back slide deck up back, I appreciate it. I did before I go on to the last couple slides and then we do our Q&A. I did want to invite Ian and the Hilltop team to just comment for a second about the probabilities that have been developed out of this model, about the sensitivity of those and how close they really track to actual utilization.
Sure, happy to, Chad. So we have done probably 6 different iterations of that type of likelihood analysis. So we've done it both in what's called a holdout population, where we have the model trained on a certain proportion of the Maryland primary care population, and then test how good the model is at predicting those avoidable hospital events on a subset of those, as well as really how this is going to be implemented, which is trained on a model then predicting the next month's avoidable hospital events. And our goodness of fit is pretty consistent over each of those iterations, and it's getting better as the model learns over time. So if you look at the top 10% riskiest patients in the Maryland primary care cohort, that it captures about 50%, about half of the individuals who are going to have an avoidable hospital event in the next month, right? So for a given practice or CTO catchment, if those individuals talk to the top 10% riskiest patients in their panels, they will have talked to about half of the individuals who are going to have an avoidable hospital event in the next month. Now, if you go down to the top 20%, that is about 2/3 of the individuals that have an avoidable hospital event in the next month, or almost 70%, right? So if you talk to the top 10% riskiest, you'll talk to about half of the people who have an avoidable hospital event in the next month. If you talk to the top 20%, you'll talk to about almost 70% of the people who are going to have an avoidable hospital event in the next month. So, we feel really good about that. And when compared to the financial risk scores like HCC and so on, this tool does much better at predicting that specific outcome of an avoidable hospital event.
Thanks, Ian. I hope that's helpful for everyone, and happy to take more questions in a few minutes here. Just a couple of wrap-up items, which is, so you've seen the current release now. That has the probability percentage for every beneficiary attributed to your practice. What we are already starting to work on next phases of the model for next year. And that will include several items as we work through that. We don't have the exact timing as we're trying to build these pieces, but we do want to provide a listing of the most salient clinical and environmental risk factors that drove that score for each beneficiary, to give you a little more insight as to, A, where did it come from, and B, where are potential areas for us, the practice, to intervene with this patient. We are also working on incorporating, right now we have social needs and determinant data based on the zip code level information that we have. But now that we have beneficiary addresses, we are working on tying that data to other address level information that would further refine the social determinants, social needs data that's applied as a risk factor to the patient. We're also working on including more advanced machine learning algorithms. I'll leave that to the Hilltop team to give you more detail, but we are working on iterations of the product. And then finally, we're also working on drill down so that you could actually click into the beneficiary like you can in other parts of the report and get history on their avoidable hospital score and how that's changed over time. Next slide. So as Audrey mentioned, this is going to be released tomorrow on the 11th. So you should see that in the CRIS report starting tomorrow. Hands-on support is going to be available from your practice coach as well as the CRIS team. And in terms of the documentation, Audrey showed you a little bit of what's already built into the report help section. We're loading up reports there. We're also going to make those resources available on the CRIS training materials website. Further, we will put these documents on the MDPCP webpage for practices, so you can see that as well. We're going to be including essentially a two-pager that is the recommended way to use the document. So for those who need sort of just a quick look at it and don't have time to read through the longer documents, the brief document and the full documentation, we put together just a quick two-pager to say, here are the screens you're going to see, and here's how we'd recommend using it, and then incorporating it into your care management workflows. And finally, we'll be sharing it with the CMS team as well so that they can post to the Connect site. If there are questions in the meantime or as this goes on, we welcome them. Please email us at mdh.pcmodel@maryland.gov. So with that, we'd appreciate feedback and comments and questions. If you want to go into the chat function of the Zoom, go ahead and put those in there, and we'll start responding to those one at a time.
Chad, thank you very, very much. There are a few questions, and let me read off. The first one was, you mentioned the report is monthly. When and how will we know the data has been updated each month? It'll be about the second Friday of every month. There'll be the CRS notice that goes out. Will alert you to that. It should appear for the first time tomorrow, which would be the second Friday of this month. And then about the same time each month. We'll point out again, this is once a month. It's static for the rest of the month, so it gives you a great opportunity for your workflow to take a look at that at the beginning. As soon as the information is available, it predicts events that will occur over the next 30 days. So there's sort of a sense of, let's look at this now and avoid those things for the next 30 days. Would become less powerful if you waited 30 days to look at it. So this is take a look. It's in the mail. Let's open up that mail and see what we can do with it. Nice, simple workflow. Second question is it possible to load non-MDPCP patients into the tool? We can't do that now. It requires claims data. And now the claims data is limited to the CCLF, Medicare fee-for-service beneficiaries data. We do anticipate that as MDPCP adds more payers, commercial payers, and Medicaid, that in the future we'll be able to load those claims in. The tool is able to accept all claims. It's not a matter of the tool's capability. It's a matter of having access and programmatic permission for those other claims.
And Howard, if I could add,
Sure.
if I could just add to what you said, Howard, which is the other piece that we have to have, which is the harder piece, really, to be able to incorporate into any of the CRS reports, is we have to have the attribution of the patient or the beneficiary to the practice, and we only have that for the MDPCP attributed beneficiaries.
Correct. Exactly. Thank you very much, Chad. The next question is, okay, so when we get this high score without knowing what's driving the score up, what should we do about that? And that's where clinical intuition would come into play. The score predicts that these are individuals who are likely to have an unnecessary utilization in the next 30 days. The clinicians will know those patients and understand what their medical conditions are, and at a minimum would say we need to see this patient and determine what their further needs are to avoid unnecessary hospital or ED utilization. In the future, again, and this should be in the very near future, there'll be a drill down that will allow practices to see what features from that patient are the ones that are driving their risk for PQI or unnecessary utilization. But those features may not be the only thing that need to be attended to. What this does is it simply says, here's a group of patients who, unless you do something about it, and the something is really up to you at the practice level clinically, they're at high risk for going to the ED or the hospital. And again, clinical intuition layered on the data is how we really make this work. Another question, could Hilltop consider using hospital attribution in a future iteration for hospital-based users? I think that that's a consideration. We haven't addressed that yet, but again, it would be a matter of access to data and as Chad pointed out, also being able to do appropriate attribution.
Yeah, Dr. Hatt, this is Ian. If I could just jump in real quick. So, as I mentioned, this tool is built on an event prediction, methodology and framework here at Hilltop. The way that the tool works, it is built to be flexible, right? So for this implementation with the Maryland Primary Care Program, as Chad noted, it's built on that attribution and the CCLF data. I think my hope personally, and hopefully it's Dr. Hatt's hope too, is that the Maryland Primary Care Program continues, its phenomenal expansion and really starting to cover a greater share of the population. If there is a desire to implement the tool kind of separately on a system basis, feel free to reach out to me. We can figure that out too. Again, we built it to be flexible, and I hope that it can cover as much people as possible during, within the Maryland Primary Care Program. But if there's patients for which it will be beneficial outside of that, we can certainly, work with you to try and figure something out.
Yeah, thank you, Ian. Thank you very much. And to that great point, it is a tool, and like any other tool, if it's going to be effective, it needs to be used. So one of the things that we anticipate and hope and will continue to encourage that practices and care transformations actually take this tool and use it, so we can really demonstrate the practical effectiveness of it in workflows and in doing what it intends to do, which is reducing unnecessary utilization. So this is meant to be a simple tool with a simple workflow and a simple implementation so that it can be broadly adopted. And again, not to replace any other risk stratification or any other tools, but to be laser focused on avoidable utilization. Any other questions from the field? Well, wonderful colleagues, any last comments?
None for me.
Okay. So I'd like to thank Ian Stockwell, Audrey Spader, and Chad for this presentation, and wish you all well. And it'll be in, as I say, in the mail tomorrow. Starts on September 11th. Thank you all very much. Have a great day. October 11th, sorry.